Welcome back, peers, to today's Explainer. We're about to bridge a massive gap in modern healthcare. We are going to connect hands-on pediatric clinical assessments, the growth charts, the milestones, the newborn screens, directly to the meticulous, compliant documentation that's actually required to validate those diagnoses in the medical record. As clinical documentation integrity professionals, or CDI specialists, understanding this clinical to coding bridge is absolutely vital. Here is our agenda for today. 1. Pediatric growth screening standards. 2. Tracking developmental milestones. 3. Newborn and pediatric lab screening. And 4. CDI and clinical validation queries.
Section 1. Pediatric growth screening standards. The clinical foundations of growth. Okay, to document growth accurately, we've got to start by clearly delineating our screening tools. A major source of clinical confusion comes from simply using the wrong chart for the wrong age. It's literally like using a yardstick to measure millimeters. The CDC explicitly recommends utilizing the World Health Organization, or WHO, growth charts for infants from birth up to 24 months of age. These WHO charts describe optimal child growth in environments across 6 countries. Then, once a child turns 2 and we can finally obtain an accurate standing stature, we transition to the CDC growth charts. Getting this distinction right off the bat is our first step in solidifying objective clinical indicators. Now, when we plot this objective data, we start uncovering potential diagnoses. Take a 21-month-old boy named Caden, for example. By tracing his length and weight, we find the intersecting points on the curves. His length sits right at the 50th percentile, while his weight hits the 75th percentile. These percentiles rank the individual against a reference population, and honestly, they are crucial clinical indicators. If a child's plotted points suddenly drop across major percentile lines, well, that is exactly the raw clinical data we need to query for a condition like failure to thrive. And this brings us to a huge milestone, age 2. The moment a child reaches 2 years of age, we begin formally calculating and documenting body mass index, or BMI. This is a critical mathematical indicator used globally to formally screen for childhood obesity and to track weight management interventions. Section 2. Tracking developmental milestones, mapping the matrix of childhood development. So, we have a whole matrix of validated tools available to screen for developmental delays. We've got clinician-administered tests like the comprehensive Bayley-3, which evaluates 5 domains and can take up to an hour. On the flip side, we have parent-completed tools like the ASQ-3 and PEDS. The ASQ-3 uses 21 age-specific questionnaires that a busy parent can knock out right in the waiting room. For us in CDI, when these screening tools indicate a delay, that score isn't just a subjective little note. It becomes a validated, objective piece of evidence in the health record. That is far more powerful than a simple chart note saying the child seems behind.
The really crucial point here is that these tools are actively surveilling very specific developmental domains: gross motor, fine motor adaptive, language and speech, and personal social skills. By tracking these domains, clinicians turn subjective behaviors, like, say, a child not waving bye-bye, into hard, objective clinical indicators of developmental delay for the medical record. And that paves the way for both targeted interventions and accurate coding.
Section 3. Newborn and pediatric lab screening, mandated testing and risk assessments.
Before a baby even leaves the hospital, they generate a mountain of clinical data. State public health agencies utilize guidelines based on the RUSP, or the Recommended Uniform Screening Panel. This panel screens for 34 core and 26 secondary, catastrophic but totally preventable genetic and metabolic conditions, starting with PKU. Documentation of these tests and their results is absolutely mandatory for establishing compliance and ensuring early treatment.
Now, beyond those first few days, we also track targeted laboratory screenings chronologically. Lead exposure is a prime example of this. The Bright Futures guidelines advise clinical risk assessments for lead at 6 and 9 months. But notice what happens at 12 and 24 months. Actual blood lead testing becomes a targeted requirement for specific risk groups. These milestones, which are dictated by Medicaid and housing built before 1978, are exactly the objective lab results we are hunting for when auditing a chart.
Section 4. CDI and clinical validation queries, the clinical to coding bridge.
Right, so how do we actually document this clinical truth compliantly? According to the newly updated 2026 AHIMA and ACDS guidelines, our queries have to be meticulously structured. The contrast between a good and bad query is wild. A compliant query states the objective fact, like the weight dropped below the 5th percentile, and non-directively asks for clarification. But a non-compliant query, it leads the provider by inserting a diagnosis, and disastrously, it mentions reimbursement. Under absolutely no circumstances can a query mention financial impact, denial mitigation, or quality measures just to sway a provider's response.
Furthermore, we have to give the provider a chance to exercise independent clinical judgment. When you issue a yes/no query, say to establish if a condition was present on admission, you are required by the 2026 standards to include an unable to determine option. Now, this isn't the same as saying possible or probable. It reflects true clinical uncertainty at the time of documentation, giving the provider a safe, fully compliant way to say, hey, I just don't have enough evidence yet.
Let's link this all back to those pediatric growth charts. When we evaluate those trajectories, specific mathematical thresholds become our objective clinical indicators. If a child's weight falls under the 5th percentile, boom, we have the clinical indicator to query for failure to thrive. Conversely, if a BMI calculates equal to or greater than the 95th percentile, we have the exact clinical indicator to query for childhood obesity. By citing these specific numbers from the chart, we ensure our queries are completely objective, not just subjective interpretations.
So, to seamlessly bridge this gap, you're going to want to follow these exact steps. 1. Extract those objective indicators, like a 95th percentile BMI or a failed ASQ-3 score. 2. Cite exactly where you found it in the record, including the date and author. 3. Formulate a non-leading question that doesn't suggest a preferred response. And 4. Provide clinically supported answer options, including the ability for the provider to add their own alternative explanation. This is exactly how we extract clinical reality into a compliant business record. At the end of the day, ethical practice is the core of what we do. We aren't just pushing paper or trying to game the system for maximum codes. As the 2026 AHIMA and ACDIS guidelines explicitly state, our true duty is ensuring that the health record accurately reflects the patient's condition. Every single percentile plotted and every query written isn't just data entry. It's about getting the story of that child's health exactly right. Think about how you evaluate your next pediatric record. Are you accurately extracting those growth and developmental indicators to uncover the real clinical truth? And are your queries absolutely free of leading language? Keep that in mind next time you open a chart. And please, like, share, subscribe to Decode Healthcare with Harshal.